And we're going to go ahead and get started. That's always my cue to say we're ready. So again, welcome to our Time to Act Substance Abuse Echo. If you've not taken a minute, put your name and contact information into the chat. As you can see, we are recording today's Echo session. We use that for educational and quality improvement purposes. They are stored on our Canvas page as well as our YouTube channel. So you are always able to go back and review some of the things that are talked about in here. Our Canvas page, I'll talk about that in a minute, but that is where we store all of our information. Echo is an interactive community, so please, if you have questions, put them in chat. Kurt Phillips monitors that chat for us, so he will be sure to get your questions answered or figure out a way to make sure that we know what you are needing. We hope that you will be interactive and turn on your cameras. I know this is during lunchtime, so sometimes cameras being turned on while we're eating isn't always the best, but please take a minute to do so. It's always great to see everybody on call. Again, we will have a case narrative, and that's a great way to get useful information from everybody on this call. So if you're interested in doing a case narrative or discussion, please consider presenting one to us. You can reach out to Project Scope at usu.edu. We talk about some sensitive topics, and we work in healthcare fields or education fields. So please remember to protect individual privacy. If you have any questions about that, you can reach out to one of our amazing hub members. They all have an asterisk in front of their name, so they are easy to locate in your chat button. The key components of an Echo session are a didactic speaker. Then we do a case presentation where all of you guys on the call give amazing recommendations. If you ever want to go back and look at the amazing recommendations that everybody has given on past cases, they are stored on our Canvas page. So we have, between you all on these calls, we've given over 900 recommendations just since January to case presenters. So then they're able to take that information back with the families they work with. These calls are also a way to build up professional networking. So perhaps Kurt had something really amazing to share, and I want to follow up with him. I can then reach out to him personally and say, Kurt, tell me a little bit more about whatever it was that he was talking about. Which is why, again, it's important to rename your profile and where you work at so that we can all get to know each other on call. I mean, if we were in person, we'd be doing some debriefing probably before and after the session. And so we're trying to create that virtually with it. Again, raising your hand. You can raise your hand or put them in chat, however you would like to do that. We email a credit of attendance after you complete the survey. So throughout today's session, we will be dropping our survey link. I just really appreciate everybody who always fills those out. They are what we can take back to our funders to say what our impact is. And so it's a way that we can utilize that and keep these sessions for free. And that's how we mail out the credit for attendance that you can then turn around and use for your professional organization for continuing education. Canvas is where we store everything. So if you have not gotten access to Canvas and you would like that, please email projectscope@usu.edu and we will get you access to our Canvas page. Case studies, again, are just a great way to, we work with some tough cases and sometimes we get stumped on what to do. And so case presentations are a great way to hear from everybody on the call, recommendations or resources that we're not aware of with that. So they don't need to match the didactic presentation. They just are a case that if you're struggling with and want some amazing resources and brainstorming with all of these colleagues on the call, feel free to reach out to us, and you can just reach out to projectscope@usu.edu. We do have Facebook pages that we share information, that we give about our upcoming sessions, things that people share out to us. So if you want to take a minute and follow us, I am going to stop sharing and turn the time over to Tricia Bishop from DHHS, who is going to be our didactic presenter today.
So thank you for inviting me today to present. I have participated in a few of these as well. So first of all, let me introduce myself. My name is Tricia Bishop. I am the overdose prevention harm reduction specialist, harm reduction coordinator, excuse me, in our violence and injury prevention program at the Department of Health and Human Services. So I have been in a few different roles under the Department of Health umbrella, and to just give you a little bit of that background, in 2017, I was a health education specialist in our HIV program, and my primary role was overseeing our syringe exchange program. So I had a little bit of experience. I had about 2.5 years under DHHS's umbrella with our new end of 2016, 2017, when syringe exchange became legal. So we're going to talk a little bit about that, but we're going to talk a little bit about harm reduction as well. So I was in that role for about 2.5 years, and then I left DHHS for a year and came back and took on more of a role in our violence and injury prevention program, doing our Naloxone distribution program. I believe my now colleague, Carla Arancibia, she is our new Naloxone distribution coordinator, basically within our violence and injury prevention program. So she oversees our purchase and distribution of naloxone, fentanyl test strips, xylazine test strips. And I'm going to talk a little bit more about that as well within this presentation. So I am currently overseeing, we sucked in our syringe exchange person into our violence and injury prevention umbrella. So now I am overseeing the syringe exchange person who oversees that program, as well as our naloxone distribution, our outreach coordinator, which I mentioned is Carla, and we have an intern working with us. So the structure under VIPP is a little wonky, and it could take me another 3 hours to, 1, comprehend it myself, but 2, try to explain it to you. So there are a lot of different components under that violence and injury prevention program in our Office of Health Promotion at the Department of Health and Human Services. That was a lot. Okay, so moving forward, I know that, I don't know if all of you have been on these calls from start to finish, or start to today. But I do feel like there's been some similarity in some of the presentations, and I know that what I present on will probably be some similarity. So I thought what I would do was take it in a little different direction and talk more about what the Department of Health and Human Services does under that big umbrella, and how our syringe exchange program works, how our naloxone distribution program works, how we are funded, and some upcoming things that we are doing within our program. So I wanted to start off again with this definition of harm reduction. And as we move forward with stuff that we're doing in the Department of Health and Human Services, and where some of our funding is coming from, we are looking at these definitions. So SAMHSA here defines harm reduction as this practical and transformative approach that incorporates community-driven public health strategies, including prevention, risk reduction, health promotion, to empower people who use drugs and their families with the choice to live healthy, self-directed, and purpose-filled lives. Harm reduction centers the lived and living experiences of people who use drugs, especially those in underserved communities in these strategies, and the practices that flow from them. So we are looking at kind of these 3. We have a set of evidence-based strategies, as a set of evidence-based strategies as an organizing principle for client-centered treatment, and as this personal philosophy. So I think this is a great tool, this harm reduction framework. This tool can be found on SAMHSA's website. This is a tool that you all can look at, can download, can use for your reference. I can make access to this as well and find the link so you have that access as well. But I think when it comes to harm reduction, there are three ways of kind of thinking about this. Again, as this evidence-based practice, as an organized principle for client-centered treatment, and as this personal philosophy. So as the evidence-based practice, some examples of harm reduction services within that evidence-based practice include our overdose reversal education and training services, navigation services to ensure linkage to HIV, to Hep C, to testing, to treatment, and other services that might be in that umbrella of harm reduction. Referrals to, again, Hep A, Hep B vaccinations to reduce viral hepatitis infection. Providing provisions of education on HIV and viral hepatitis prevention, testing, and referral to treatment. Information on local resources and referrals for PrEP, which is the pre-exposure prophylaxis. And then syringe exchange services and access to programs. So there's your set of evidence-based practices. Under the client-centered treatment, healthcare workers in different contexts have created different versions of harm reduction therapy. But it is used as an umbrella term for a range of therapies that is oriented towards improving people's lives without necessarily insisting on abstinence as that initial goal. I think we know, most of us on this call are very familiar with harm reduction, and we know that harm reduction is a spectrum. It's a long line of somebody might choose abstinence, but somebody might not choose abstinence. And it's that wave of that, it's this person's journey, it's that person's journey. They get to decide on that spectrum where they fit. And then harm reduction as a personal philosophy. It begins at the most fundamental level, with recognizing that all people deserve safety and dignity. It does not treat drug use as a moral failing. And this is specifically information from Johns Hopkins University, recognizing that inherent worth of people who use drugs and meeting people where they're at, and working towards any positive change. So I love this. Again, this was on the SAMHSA's website. I know that at the DHHS level, at the Department of Health and Human Services level, we've had some growing pains, and we've struggled a little bit with getting information out about harm reduction. And I think sometimes we need to remind people that we have been messaging around harm reduction forever. And I do think harm reduction kind of gets a negative label, negative connotation behind it. And a lot of people think harm reduction is just about drug use, is just about syringe exchange, is just, it's around this disease world that is often, again, has that negative context, negative stereotype with it. And I think, again, we need to remind people that these are all forms of harm reduction that we have been educating people on for many, 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 many years. Whether it be the fire extinguisher under your kitchen sink that you have, or the fire alarm that you have, or the seatbelt that you use when you get in your car in the morning, or the sunscreen that you put on, or the soap that you're using to wash your hands with after you use the restroom. There are so many things that we should consider harm reduction that are already in our toolboxes. So I wanted to talk again about some of the stuff that we see at DHHS. This is probably information that you might eventually get disseminated to you. We have, I mentioned 3 people who work directly with me. I also have an intern, but we have our epidemiologists on our non-fatal and fatal data, and they're looking at that data for us, and they're getting this information for us so we can look at trends. So just a bigger picture look at what's been happening when it comes to drug trends in the United States. Well, not in the United States, excuse me, in Utah. But you can see that our numbers are kind of increasing. You can see that our fentanyl numbers have gone up a lot. You can see that methamphetamine still remains a serious problem. And I think that's one thing within the Department of Health, within my role, within Carla's role, within Hannah's role, who's our syringe exchange specialist, we're looking at these trends, and we're looking at, we talk a lot about opioids, but methamphetamine is not an opioid. And I think we also need to think about that when it comes to how we are sending messages out there. And I think one thing that we are learning, that the opidemic is not a single drug anymore. It's a polysubstance opidemic. We are seeing lots of our drugs being adulterated with other drugs, whether they're classified drugs or not classified drugs. Just having a conversation in a staff meeting about the amount of veterinary medicines that are being adulterated and put into our drugs because they are not under lock and key, and people have a little more access to those drugs. So I think we need to, again, keep on top of this data. We need to keep on top of our trends, and we need to think about how we are messaging, and we can't forget also about especially that bottom one on this summary. Methamphetamine still remains a serious problem in Utah. People in Utah like meth. And they use it a lot more. We do have, if you look at our seizure data, we might be seizing lots of cocaine and lots of opioids, and some of that isn't meant to be here. We live on some pretty major interstates, and that stuff is coming up I-80 and maybe headed towards California or I-15 and headed somewhere else. So the drugs that we are seizing, good that we're seizing them, but not always meant to be kept here in the state of Utah. So we have to, again, reevaluate and look at this, and we need to do a little bit better job around messaging when it comes to, are there overdoses happening from meth because of overstimulation, because of overramping, and thinking about those types of messaging. Continued here, you can see that in 2023, 591 people died from drug overdoses in Utah. That represents, again, a 10% increase from 2022. The crude rate being 100,000 in 2023. Reporting period is 17.1, which is significantly different. Significantly higher than the rate in 2019. So we are seeing this, again, still upward trend when it comes to overdoses in Utah. So knowing some of those principles behind harm reduction, thinking about those evidence-based practices, thinking about the client-centered treatment, thinking about those personal philosophies, what are some of the things that we are doing at DHHS? So for those of you who aren't very familiar with syringe services, we're going to talk a little bit about that now. So in 2016, Utah legalized syringe exchange. They made it legal for organizations to exchange used syringes for unused syringes. So prior to that, it was happening in Utah underground. It was happening by organizations who knew that the community needed access to unused syringes to help with disease prevention. So our syringe services, sorry, I'm moving my images around here a bit, the pictures of all of you, so I could see some of my slides. So SSPs, syringe services programs, are community-based prevention programs that provide a range of services, including linkage to substance use disorder treatment. access to disposal of sterile syringes and injection equipment, vaccinations, testing, and linkage to care and treatment for infectious diseases. So this might be some of the terminology you hear in the community. This might be some of the terminology that you've seen. I know when I started in the field 20 plus years ago, I was working with HIV and AIDS education, and that's when I was introduced to harm reduction. And I am originally from Wisconsin, and 20 plus years ago, there was a syringe exchange. There was needle exchange programs happening in Wisconsin 20 years ago. That was part of the organization that I worked with. It was legal then. It's still legal now. So some of our communities are taking some baby steps. And I hope that we continue to do this powerful, meaningful work to help save people's lives in our community. So you see the different language here. It could be syringe services program. It could be syringe exchange program, syringe access program, needle exchange program. Some of them might feel a little more encompassing than others. I think SSP, syringe services programs, feels like it's not just the exchange of syringes. It's also providing other resources to people who use drugs. So what is the impact of our syringe exchange programs? What we know is our clients, our participants are 5 times more likely to enter drug treatment than those who don't use syringe services programs. They are also 3 times more likely to report a reduction in injection frequency than those who've never used an SSP. I think there is there's a myth that if we give people clean works, if we give people safe injection equipment, that they're just going to use more. If we offer this, then people are just everybody's gonna start using drugs. And we know that there's no science to prove that. I think we've also seen that very similarly when it comes to safe sex education, when it comes to condom use. And we know that if we give young adults condoms, that doesn't mean that they're going to have more sex. It's just a way to help. It's a tool in their toolbox to potentially reduce an STD or reduce a pregnancy or prevent a pregnancy or prevent something. Also, some of the impacts of SSPs are 50% reduction in HIV and hepatitis C, as I just mentioned, HIV. So our syringe exchange program and our oversight of our syringe exchange program fell under initially the umbrella in the HIV program. So it was part of, we at DHHS wrote to the administrative rule. We were told syringe exchange in 2016, December 2016 was legal. And we had to write the administrative rule to put that kind of law into place. We were not given any funding to do that either. My colleague, my friend, who's no longer with us, Heather Bush, was a very important proponent in the success of our syringe exchange in the state of Utah. And I continue to channel her every day when I do these presentations. So again, it was under that umbrella of HIV, primarily for disease prevention. The things that are required of individuals who participate or organizations that participate as a syringe exchange program is they have to offer HIV testing and hepatitis C testing. They have to provide some type of a referral, and that could be a written referral, that could be giving them a pamphlet of information where they can get more information. Our syringe exchange programs are not, what's the word I'm looking for? It is similar kind of to a bridge program, but our syringe exchange programs don't do everything. They provide as many resources as they can, but a lot of times what it is they are referring to a treatment center. They are referring to a bridge program to get them buprenorphine or get them the medication that they need. So they're trying to be a little more wraparound. Some of our syringe exchange programs do have capacity and capability to offer counseling and therapy within their organizations. Some do not. So this again, as I speak before I get to my slide, shows all of the things that our syringe exchange programs do provide. And you see it's a lot. I will say if an organization registers to become a syringe exchange program, these are not requirements, but these are all things that a handful of our syringe exchange programs are able to provide. So you can see it's a lot. Please stop me too if you do have any questions, or we can also ask questions at the end. I should have some time at the end as well. So you can see that they offer a lot within their programs. Some of our syringe, and I'll show you this, as again, I keep jumping ahead of myself. These are our registered syringe exchange programs within the state of Utah. So Southeast Health Department, Salt Lake City Fire, Tri-County Health, UHRC, Utah Harm Reduction Coalition, Moab Regional Hospital, Utah AIDS Foundation, Soap to Hope, Utah Naloxone. Hand in hand is in the St. George area, Odyssey House, primarily in our downtown Salt Lake area, the VA, and then Salt Lake Harm Reduction Project. I will say we are probably adding one to this. Bear River is going to establish themselves as a syringe exchange program, and utilize some of the funding that we are able to give them to help link people to more resources and more services, and navigate them to care. So these are the locations of our syringe services programs currently. You can see there are 1, 2, 3, 4, 5, 6, 7, 8 of them, like I just kind of mentioned. And they don't cover all of the areas of Utah. So it can be hard, it can be difficult for some of our rural areas to get access to services if individuals need them and they live somewhere that's too far away, and they can't get access to those services. You can also see by county. Salt Lake makes up the biggest amounts, and you can see, I say that there are 8, the 8 listed here, and let me take my words back and look at this previous map again. The 8 listed in that box are all Salt Lake County providers. So you can see we have saturated Salt Lake County really well. All of those locations, all of those organizations are in our Salt Lake County area. Is that where we have probably the biggest populations? Yes. So it kind of makes sense. But there are, again, communities that don't have access to all of these services, and we are hoping that we can continue to show those counties, to show those communities the data trends and back to the trends that we spoke about, and that data, and show that there's a need for these services within our community. So what are our participants saying? Those people who are involved in our syringe exchange programs, that it's not enabling, it's harm reduction, it's a beacon of hope because it shows people care, and no judgment, that it serves a very real need and keeps people from using other needles, and from throwing them away just anywhere. It has helped this person stay positive and productive in everyday life. Ultimately, I was able to get the help I needed through them. So in 2018, we started evaluating, after a year and a half of the legalization of syringe exchange. We started evaluating whether or not participants felt like this was effective and useful. And I was involved in that evaluation process. I went out with a colleague and we surveyed individuals. We were able to provide them a very small incentive for participating in the survey. And it was very, very eye-opening to hear the stories, to talk to the individuals, to talk to the people that I think sometimes do not feel like they are treated like human beings. and they just want somebody to listen to them. And we asked them a handful of questions, and I think these statements kind of emulate what we also got from that evaluation, was that that people do care, that we want to listen to them, that people have changed and they wouldn't be where they are today. They might not be alive if this program was not able to help provide some services for them. Understanding again that harm reduction is this journey, and we have to be okay when we are out there in the community helping individuals, understanding that it's not our journey, it's their journey, and they might not be ready for that abstinence-based only program, and they might fall off the wagon 6, 7, 8, 9, 10 times before they might be ready to try something different. So the role of our syringe exchange specialist, so what Hannah does a lot is she enrolls our new syringe services program. People can fill out some enrollment forms. We need to keep track of that. So, and I say that, again, the state made it legal in 2016 for syringe exchange to happen. And we wrote the administrative rule. If people want to do syringe exchange, they need to register their program with us. Otherwise, they could get in trouble. So I think ultimately what we are doing is helping that organization so they do not get in trouble with the law and they are a registered program. She also monitors existing programs, and here's those legal requirements: education, referral, reporting. We are able to fund a small handful of our programs with never an adequate amount of dollars. I think we all would love more money to be able to effectively reach some of our at-risk communities. But because of the funding, we do require some reporting from our agencies, and they keep track of all of their encounters. Each person who enrolls in our syringe exchange program is given a unique code that includes letters from their first name, letters from their mother's first name, and then I think we do day. We exclude. I think we exclude it's like month and year of birth, or month and it might be the day and the year that they were born, and exclude one. Like there could be 1 million people born on August 6th, but August 6th, 1974, like narrows it down that much more. So one of those 3 numbers in there is eliminated from that code. So we are keeping, we are reporting. We are looking at our data from that to see what information we can collect from there, what trends, do we need to be doing more syringe exchange in that program? Are there other resources that need to be going out into those communities? As I said, we were able to fund some of our syringe exchange programs. We do have funding, our state opioid response grant, which is a SAMHSA grant, which is administered through our Office of Substance Use and Mental Health at the Department of Health and Human Services. They are able to give us dollars to help support our syringe exchange programs. And then this person also provides training and educational opportunities. So we usually, in combination with, you will see our Utah Syringe Exchange Network, in combination with our Utah Syringe Exchange Network, help facilitate a harm reduction navigator training. We are working on, we have an intern with us right now who will also be working on changing some things up with our harm reduction navigator training. And again, working with our Utah Syringe Exchange Network and people within that network to help us present on the importance and what people need to know, what our syringe exchange programs need to know when they are enrolling as a syringe exchange program throughout that training. So USIN is our syringe exchange network. As I said, it is a combination of community-based organizations, Department of Health and Human Services. We do have individuals who participate in USIN. USIN meets, I think it's now on a bi-monthly basis. and I would have to go back and check. Anyone really is invited and can attend our Utah Syringe Exchange Network meetings. We usually do a lot of updates around what the other syringe exchange programs are doing. We work through some, if we at DHHS have any updates. We've presented before on legislative stuff that has come out. But I do think it's an opportunity for not just DHHS. It's this opportunity for DHHS and again, other community-based organizations to come to the table, to have people at the table with lived experience come to the table and have a conversation about what is working and what is not working within our syringe exchange programs at the state. Naloxone distribution. I mentioned briefly about my new colleague, Carla Arancibia. This is a program that I used to be overseeing. She is now overseeing it. So just to give you a little bit of the landscape of naloxone distribution within the state of Utah and what it has looked like over the years. So in 2014, a law was put into place, the Naloxone Access Law, which allows third-party prescribing and dispensing. It allows immunity from liability and requires third party to advise persons to seek medical attention. So what this has done is this has given me the capabilities of purchasing naloxone in bulk and distributing it to all of our community. There are other states who do not have this access law in place. For example, Idaho does not have this same law in place, meaning that their naloxone is purchased through EMS or medical somehow, and that is the only place it can be distributed from as well. It can't be given to anyone, and it wouldn't ever come to me, so I could distribute it out to other local health departments or other community-based organizations or our syringe exchange programs. It all had to come through their EMS system. So this is great. This has allowed us and allowed staff like me to make it more accessible to our community-based organizations. In 2016, we created the Opioid Overdose Response Act, and this is what we piloted now from 2014. Now we have this access. We can purchase naloxone. We can now purchase it in bulk, and we're going to pilot this. Let's get naloxone out there to our community-based organizations. So we did more of like an RFP. People had to submit their requests for proposal. They had to submit their why they wanted naloxone, what they were going to do with it, how they store it. And then it was on we got to review them and determine who we awarded naloxone to. Since then, and since the dollars that we get from SOR, I don't know that they've necessarily increased, but we no longer, I want to say, people still have to fill out a request form for naloxone. I and Carla get to use a little bit of discrepancy when it comes to who the naloxone goes to. But it is less of a competitive process, I will say. And then the last thing on here, and I can explain a little bit more about that naloxone process as well. So I don't think this is the one I needed to change. I think this happened in 2022, naloxone without prescription. Or no, maybe this was 2023. 2022, what happened was naloxone, you no longer needed a standing order. In 2022, HB 178 was a bill that was passed that I didn't put on here, that what it did was it made medication like naloxone, it made birth control, it made smoking cessation, and it made HIV, PEP, and PrEP accessible without a prescription. So people they no longer needed to have a prescription on hand to get it. It was a standing order that was kind of put in place for all of those things, and you didn't have to walk up to the pharmacy and have a prescription to get your birth control. You could now just get it. So from 2022 to 2023, in the overdose world, we now made naloxone available without a prescription, and it is now over the counter. which is great. I encourage you all when you go out to your Walgreens or Walmarts or whatever marts you choose to go to take a look and see where naloxone is and look at the pricing. When it first became over the counter, I think it was in the $44 arena, and that was not that long ago. And I think since that time it has dropped about $10. So I think it is now, I think my husband saw it at Walgreens in our Salt Lake City area for like $34, $35. So and I do think that there are many more companies coming out with options that might not be the bioemergent brand. We're starting to see more potential generic brands coming out. So funding, how are we able to do all of this? So the Department of Health and Human Services Violence and Injury Prevention Program receives state opioid response dollars from our Office of Substance Use and Mental Health. Those dollars, they're federal dollars, they're SAMHSA dollars that allow us with our naloxone program, our fentanyl test strip program, xylazine test strip, they allow us to purchase naloxone, fentanyl, and xylazine test strips. We do have priority populations, and this is where I say myself and Carla get to use a little bit of discretion when it comes to who we are distributing our naloxone to. I think it's important to note that we want to saturate our high-risk populations. And our high-risk populations tend to be, again, our nonprofit community-based organizations providing syringe exchange to individuals on that spectrum of substance use, homeless programs, veterans organizations. So those are kind of like my three top yes, no questions. First responder, fire, EMS, obvious, we're going to give them to them. Law enforcement, courts, criminal justice partners, elementary school and high schools. So I will give elementary schools and high schools these for their front desk, their nurses stations. I do not do a lot of distribution to our colleges and universities. And I will say, one, because I need to saturate my high-risk populations, and I don't want to say that our college students are not high risk, because I was a college student once, and I was a college student in Wisconsin once, so much different than being a college student in Utah. So I know the risks are high, but I also think that we need to kind of tell our colleges and universities to invest in our students a little bit more and use some of their dollars to provide naloxone to their student populations if they can. Because I really don't have enough. If I could give naloxone to everybody, I would, and I don't have the dollars to support that. I have got to look at those priority populations first. So ask your football teams to give you all some money. And then obviously we give to our local health departments. And this is where I hope at some point this connection between having an individual, we don't do individual distribution. So if an individual requests a naloxone kit from our organization, most likely I will refer them to someone to get that individual kit. So we're giving boxes of 5, 10, 15, 20 boxes out, which each box contains about 12. They contain 12 kits in each box. So our local health departments are kind of that great connection between referring that individual who needs a kit to the local health department, not the state health department, the local health department in their community to go get that individual naloxone kit. Okay. Our policies and procedures. So we have a request form. I've linked that here. You should have access to these slides later if you do need that link as well. We make arrangements for pickup or shipment. We require that you watch a 20-minute naloxone training video, and within that 20-minute video, it explains, yes, the nasal, which is what we primarily give out. We only give out nasal. But it also goes through the different types. It goes through how to do the intramuscular. It goes through how to do the auto injector, which is similar to the nasal, but you are given a vial that you would put in something that looks like a syringe. without the actual pointed tip on it that would be pushed slowly into someone's nose. And then I think I took off of the website the Envezo, and I can't remember the name of it, but it was also kind of, it was like a defibrillator that would walk you through how to use the actual injector that was intramuscular. We know that company no longer makes those. They are no longer available. So we did take that off of our website, and it might still be included in the training, the 20-minute training. They're very expensive. They're like $5,000. And I don't know why people would purchase them. But it was a thing years ago. We do require quarterly reporting. Again, these are dollars that we're getting from our Office of Substance Use and Mental Health, and they need to make sure we're using our money the right way. So our quarterly reporting is pretty simple for anybody who has requested naloxone from us before, fentanyl test strips. It's how many kits or strips were distributed in that quarter. And if you can, were there any reversals reported? This is a hard one, and we know that we're going to have a really hard time getting this data. Same with the fentanyl test strips. Were your test strips, did you test your drugs, and was there a positive? What drug did you test that was positive? Any information that we can get obviously helps with our data, helps with looking at our trends, helps with getting information out there. I just want to show you real quick, and I hope this works, but I am not, again, the greatest when it comes to technology. But I wanted to show you this video. Can you tell me if you can hear that?
So I was able to.
Yes, thumbs up. I got a thumbs up. Okay.
Fentanyl. It's a synthetic opioid that's 100 times stronger than morphine. Just a few crumbs is enough to kill you. And any drug not prescribed by a licensed pharmacy could contain a lethal dose of it. From 2019 to 2021, Utah's fentanyl-related deaths increased by 209%. Fentanyl can't be detected by sight, taste, smell, or touch. Educating your clients on how to use a fentanyl test strip can reduce their risk of an overdose. It can be life-saving, and it's the easiest way to test a drug for fentanyl. Remind them that a test strip is a harm reduction tool, not a fail-safe method. Teach your clients the following steps to test their drug for fentanyl. Step 1. Get a clean container, like these, to hold some of the drug. Step 2. Add water. Most of the time, half a teaspoon will work. If the drug is being injected, draw it into the syringe, then add water to the residue in the container. If the drug is a stimulant, 1 teaspoon of water is recommended. If the drug is a pill, add water first, then scrape crumbs from the middle of the pill into the water. Mix thoroughly. Step 3. Open the package and remove a test strip. Make sure not to touch the test area. Any contact with it could ruin the results. Step 4. While holding the blue end, place it in the watery mixture and let the strip absorb the liquid for about 15 seconds. Step 5. Place it facing up on a clean surface and wait for results to appear. It takes about 5 minutes. Now check for results. Observe the test strip for changes. Reading the results of a fentanyl test strip is different than reading results of a COVID test or pregnancy test. With a fentanyl test strip, if 1 line appears, that means fentanyl is detected. If 2 lines appear, that means fentanyl is not detected. If fentanyl is found in a drug, it's likely deadly. Remind your clients, if fentanyl is detected in their drug, to think twice about using it or consider strategies for safer use, such as going slow and using in a group. Knowing what's in a dose can be life-saving. Keep your clients informed so that they can keep themselves safe. Talk to them about your available services and harm reduction resources. Remind them to bring the basics. Fentanyl test strips to test their drug. Naloxone, a medication that can temporarily reverse an overdose, and another person who, if needed, can administer naloxone and call 911 for help. Direct your clients to opidemic.utah.gov for additional resources.
Okay, you can see my page again that says trainings on it. Yes, okay, perfect. So, and again, that very last piece of that 3-minute presentation, you can go to Stop the Opidemic, you can go to our website and you can find the Naloxone 101 video, you can find the fentanyl test strip training video. And we ask again that people watch, organizations watch that fentanyl test strip training video if they are going to be administering fentanyl test strips, if they're going to be handing fentanyl test strips out to individuals. So they know, they understand how to have that conversation and the best way to educate people on the right way to use fentanyl test strips. And then real quickly, just to kind of wrap everything up in a way, this isn't really wrapping up, but just another source of funding that we have under the Department of Health and Human Services. So we were funded for the 2024 to 2028 years through the CDC, through their Overdose Data to Action Grant. So we call it OD2A. Some of you might have received some OD2A funding. I'm not sure who's all on this call, but this is the framework for our OD2A funding, and this is what we will be using some of the dollars for with that funding. I can tell you I cannot speak to all of these because I am not over all of these. But there are definitely people, our EPIs and our we have people who work in our Office of Medical Examiners who work a lot with our surveillance, our morbidity, our mortality, and biosurveillance in these first 4 things within that framework. So we are paying their salaries to help us look for the data. We are paying to have them figure out what drugs they had in their system when they are reporting a death or an overdose, so we can better understand how to, again, educate our community, how to educate people when it comes to providing them with harm reduction materials, supplies, messaging, whatever that might be. We have our we have an overdose fatality review committee, which I believe fits in one of these 4 strategies. And that overdose fatality review committee is made up of a good handful of people within DHHS, some outside, some clinicians, and we look at case studies. So, and usually we do this every other month. Every other month, we pick 3, they pick 3 to 4 case studies. We review them. These are overdose deaths. We, as a group of about 20 people, look at them, review them, and make recommendations. I will say a lot of our recommendations that are made are, we need more harm reduction messaging out there. And we are trying to get more of those recommendations out. When it comes to public safety, I can't speak much to the clinician health system stuff. Public safety, we work with our public information analysts and our high intensity drug trafficking association, and they provide us a lot of information when it comes to drug seizures. They're our connection to our ORS, which is our opioid response strategies group. And again, they're our biggest connection to public safety law enforcement. So they're the ones that if we can't get to law enforcement, we're going to try to make a connection with them, and then they will try to soften that connection with law enforcement. I will give you an example. So we have had some of our syringe exchange programs complaining about law enforcement coming on site, coming to a location where they are doing syringe exchange, and getting law enforcement getting aggressive, law enforcement demanding that they they themselves like have to move. Some of our syringe exchange programs are mobile, so they are going out and doing mobile deliveries. They are out there in the community. They set up shop in a public area, and law enforcement will come and harass or get aggressive or kick them out of locations. So we have kept notes. We have kept track of some of these instances. And we have gone to our public safety, to our public information analyst, to our high intensity drug trafficking association and said, hey, help us. You have connections within public safety. You have connections with Salt Lake law enforcement, Ogden law enforcement, wherever. Can we have a conversation? Can you connect us? Can we help better that connection with those organizations so we're all on the same page? Because it's legal. And I do think that there is a interpretation of the law sometimes. And sometimes law enforcement interprets it very differently than what some of our syringe exchange programs are interpreting it as. The two strategies that I primarily work on are harm reduction and linkage to care. And this is where we recently sent out a request for grant application for syringe exchange programs, for other local health departments, for agencies to apply for funding to increase their harm reduction initiatives in their communities, or to increase their navigation and linkage to care around harm reduction services. So we did have a good handful of organizations apply, and hoping to see some new initiatives again in our community around harm reduction and syringe exchange. That is really all I have, and I hope that it wasn't the same information presented just in a different way by a different person. I hope you learned something from it, and I'm here to answer any questions if anybody has any questions as well.
So there is one question in the chat.
Oh yeah.
From December Hatch, where she says she's curious to know if others have experienced the use of fentanyl test strips. The use of fentanyl test strips have declined with the increased intentional use of fentanyl specifically. That's how it is in Tri-County area.
Oh, interesting.
I don't know if anybody on the call has had that, or you have anything to add to that.
No, that's an interesting question. December, you are always also welcome to join our USIN calls that we have, and even bring this up. I can jot this down and ask our syringe exchange programs. It's funny how we keep seeing an increase in fentanyl overdose, and fentanyl is everywhere. And I don't know why more people aren't using our fentanyl test strips, and why, if there is a decline, why there is a decline. Our fentanyl test strips are fairly accurate. And I think they can be a resourceful tool for people to use if they want to know. I will say that the fentanyl test strip, all it does is tells you if there's fentanyl in your drug. That's all it's going to do. And then at that point, that individual has to decide whether or not they're going to continue to use the drug or use it in different ways. So thank you, Carla, for putting the link in the chat. Yeah, so I don't know that really answered your question around the decrease in fentanyl test strips. We have a lot of them, so request them. I hope people use them. I will say one thing that I did learn just recently. We also have some we don't have as many, but we have some xylazine test strips. Just what's hard about these test strips, similar to even any type of rapid test you do, it's different with every type of drug that you're testing. And with the fentanyl test strips, I like to tell people one line is a flat line, meaning one line could potentially be lethal, could be deadly. So there's your flat line. And obviously that's different than many other rapid tests that we all have done. Probably many of you have done COVID tests, and you're always looking for 2 lines. You're always looking for that second line to tell you if it's positive or not. Pregnancy tests the same. So with xylazine test strips, what we're learning now is that if people don't use enough drug with the test strip. So with xylazine, if they're testing specifically for xylazine, they have to use more drug than I think they would be using to test for fentanyl. So those test strips are a little less sensitive to xylazine. So if people are using xylazine test strips, they need to use more of their drug.